with me. I've been asked to talk about the complications. Quite a lot of the issues have already been raised by Dr. Boshoff and Professor Berger. But in terms of complications, there are obviously generic complications as apply to any diagnostic or interventional procedure, and these include valve damage, air or clot emboli. Remember, we're using large sheets, so clot and air are definite problems. And some of these patients also have residual right to left shunts, as if they've been palliated, so you've got to be careful about any embolization to the brain or the systemic circulation. Cardiac perforation, because we're using quite big sheets, wires, and so on. Valve damage, particularly to the tricuspid valve. You can get arrhythmias because these wires and sheets are very stiff, and in some situations you can finish up with damage to the AV node. Usually that's transient, but it can be permanent. Obviously infection, because you're putting in permanent devices like stents. And one of the complications that wasn't listed is death, and believe you me, it does occur. And I think part of the problem with if you have a bleed within the lung in this situation, the pulmonary circulation is not normal, it's usually suboptimal, and if you have a bleed in a lung with limited blood supply, then you're going to have serious problems. So I think that is something which must not be underestimated. It's not common, but when it happens, it's very serious. In terms of specific complications, there are very clear-cut ones. You can get vessel dissection. This is not usually very serious, it's usually very localized. The pressure is not usually very high, but you need to recognize that. Depending on where it occurs, it may occlude adjacent vessels, and that may or may not be important. Vessel rupture, I think this is the most serious one, because it can lead to bleeding, and therefore it can lead to death. Vessel occlusion, this does occur, or jailing with stents. It's not usually a big problem, particularly if it affects small vessels, but if you're dealing, say, with a Fontan circulation, you need to retain all the branches that you have in the pulmonary circulation. Pulmonary artery aneurysm occurs usually after just balloon dilatation with standard balloons or high-pressure balloons. These are usually localized and contained, and they don't generally progress. However, if you're going to redilate in the future, you have to be careful not to rupture them. Lung perforation, usually from wires. This is something which is avoidable, and although we want to keep the wire in position and distally, it's important not to push something like a Lundequist or a Meyer wire very, very, very far and hard into the lungs, because it will perforate and you'll finish up with a bleed in the pleural space. That is usually contained. It's not as bad as when you have a bleed within the lung and you have hemoptysis. Balloon rupture is not usually a serious problem, but it may contribute to the damage to the vessel itself, and sometimes may have problem retrieving the balloons. Dr. Boshoff mentioned very clearly on several occasions that you need to inflate and deflate the cutting balloons gently. She also listed the size of sheets that you need, and these are very, very important, because if you don't apply those rules, when you're pulling the cutting balloon away from the heart into the sheet, you can actually lose some of the blades. And one of my practice is that when I get the balloon out of the patient, I inflate the balloon and count the blades. Some have 3, and usually they have 4. So I think it's important to do that. Again, some of these patients may have residual right to left shunts, and you can finish up with a blade in the brain, and it has happened. So bear that in mind. The stents can migrate either distally or proximally, and there are ways of dealing with that, depending on the type of stent, depending on the size of the patient. You can get stent compression, and Professor Berger showed us the bifurcation stenting, and he indicated very clearly the Mullin's technique of implanting the 2 stents at the same time to avoid compression. But depending on the anatomy, that may still happen. Ingrowth stenosis we've referred to. Personally, I don't think that putting in covered stents necessarily avoids that, because the mechanism we don't fully understand, and I suspect it's intimal growth, which grows not between the stents, but also through the proximal and distal end. And then there are some complications such as left recurrent laryngeal nerve damage or coronary artery damage in certain situations. I'm grateful to John Cheetham for these, and I'll just go through some examples of... Grateful to John Cheetham for these slides. And this is a patient with very, very hyperplastic pulmonary arteries. And I think, again, Dr. Boshoff pointed out the preparation in the situation. And because the pulmonary arteries are so hyperplastic, the chances of getting a successful result without damaging the alveolar flow tract was very small. So this procedure was actually carried out under hybrid. You could see how small the left pulmonary artery was. This was eventually stented and with a very, very good result. But the important thing is it minimized the risk of getting any serious complication. When you have a very tight stenosis, it's very important not to dilate to the diameter of the native pulmonary artery. If you're just going to be simply ballooning, if you're putting in a stent, you get more controlled dilatation. So try not to go more than 3 times the size of the narrowing, because otherwise you may finish up with rupture or dissection. In terms of the major problems, they can arise quite a lot in patients with very intrinsic disease, such as Alagille's or Williams, but it can also happen in patients with congenital heart disease. So this is a patient post-truncus repair, and you can see that there is narrowing of both the right and the left pulmonary artery. The right was started off first, and it was dilated. The waist had gone, but when we do the angiogram, we see that we lose the left pulmonary artery. This was entered successfully and dilated, and we can see that we have restored flow at that point. You will notice that at the bifurcation there's a little bit of a negative shadow, and you will see it in a better projection here. At the top of the bifurcation, you can see that there is a very, very clear dissection here. But at least we have opened up the right pulmonary artery, and we still have flow to the left. So this patient went for elective surgery within a few days to deal with that problem. So it's important to recognize these complications. This is not a pulmonary artery, but a collateral. But the point I would like to stress is the same point that Dariz mentioned, and that is the interrogation issue. So if these patients with very tight stenosis, whether they're MAPCAs or native pulmonary arteries, if you have a high-pressure balloon which doesn't inflate, then you should use cutting balloons, as we've done here, because that gives you a controlled dilatation, and then you can get quite a good result. If, on the other hand, you fail to do that, you may finish up with a situation as in this collateral here, where we did not interrogate or actually dilate, and we placed the stent. This, fortunately, was just a collateral, and you can see that although we've opened it very nicely here, it concertinaed in this place here. If we did a cutting balloon prior to this stent here, we would not have finished up with this kind of problem, as that fortunately this was a MAPCA rather than a native pulmonary artery. Sometimes you can finish. This is a patient with Alagille's syndrome, and these patients do have very brittle pulmonary arteries, so you have to have a low threshold to use cutting balloons because they can rupture. So you can see that there is a tight stenosis on the second film there, which did not open up with pressure. We used cutting balloons, and then we used and then with an angiogram, you can see a very marked difference. So you can get a very, very good result and a very safe one. However, that doesn't always happen, because with this particular patient, we, on a subsequent occasion, did the same thing on the left-hand side, and I'll show you the result of that a little bit later in the talk. Stenting, as Professor Berger mentioned, it gives you a controlled and very good results. So in this situation, which is where you have a left pulmonary artery stenosis, but not very, very tight, you can actually place the stent. But you can see at the end of this that the balloon actually ruptures. But fortunately, the stent appeared to be in a stable position. Again, I will show you the outcome of that a bit later. The balloon burst completely, and there was no contrast in it, so the chances are that the balloon split longitudinally, in which case it's safe. When the balloon ruptures transversely, then many a time you will finish up with a little bit of contrast in the distal bit here. So when it ruptures longitudinally, you can pull this out very easily. When it ruptures transversely, you can pull out the proximal but not the distal. So there is a technique of doing that, and that is to leave the wire in position. You access the left femoral vein. You can pull this bit out of the skin very easily, and you cut the shaft of the balloon at that point here, exposing the wire completely. You then replace this with a multipurpose catheter and snare your wire and exteriorize it in the femoral vein on the left side. And then by pushing your multipurpose and pulling on the wire, you can get this out from the other femoral vein. And this works very, very, very successfully. In terms of stenting the pulmonary arteries, I think they are very precious. This is a patient with a CP shunt. And we can see that although it has been very, very well stented, I think some of the vessels have been jailed, and these may well close up. Placing it a little bit more proximally, I think, would have been better. It may be difficult to do this with a CP shunt, in which case you might as well wait for the Fontan completion or TCP completion, because that gives you more control as to where you place the stent. And it's been mentioned that overdilating can be problematic, and we can see here again, not only is the stent long, it seems to be very dilated here, impinging on several vessels and not really covering the proximal bit. Again, my preference would be to do this after the surgical completion of the TCPC. You can get stent embolization, and this is an embolization in a CP. Again, you have very little control with a CP compared to a Fontan in terms of space. So this stent was opened up. As you can see, it landed up distally into the left pulmonary artery. Some of the stents you can actually retrieve. You may have to compress them first. And what we've done is we used a balloon to try and bring it proximally, and then actually use a big sheath to actually retrieve it. So this is the patient that I showed you earlier, where the balloon actually burst. It looked like the stent was fully open, but when you look at the stent a few moments later, you can see it's embolized into the right pulmonary artery, and it's actually moving back and forth. There are ways of retrieving these. Many a time is not to, or bailing out. The usual thing is not to try and get them out, because they can be very, very traumatic, particularly if you have to cross valves. But you can actually secure them in another place, and you can bail them out. You can bail out by overdilating in the right pulmonary artery. Ingrowth stenosis has been referred to, and this is a patient with bilateral stenosis following a switch operation. The femoral veins had become occluded. We dilated the right, but as you can see, the left was already stented, and in fact there was ingrowth stenosis at that point. And as Professor Berger indicated, you can either initially dilate this, or you can actually put a second stent to overcome that problem. I have a high threshold for putting stents, especially pre-Fontan, and I think the reason for this is you do get problems, not very high, but cumulatively with fractures and stenosis, they do occur. This is a patient who did have a stenosis, in fact almost a complete occlusion at the site of a stent. Yes, you can dilate it, and if necessary you can put another stent, and you can rehabilitate that vessel, but they are not without their own problems. Bifurcation stenting, this can be a problem. So the techniques that Professor Berger indicated, in this case the Mullins technique of using simultaneous stents, works very, very well, because although they look very close to one another, they're in fact at different planes. However, there are situations when the pulmonary arteries are like so, which is very, very different, And yes, you can put bilateral stents, and they look much better. But when you look at them in the short axis, you can see the proximity, but also you can see the compression at that point there. Rupture, as I mentioned, is a very serious problem. And rupture can happen in two ways, either bleeding into the pleura, particularly either if you put a wire right through the lung or if they burst proximally. And this is a patient who had bilateral PA stenosis with systemic PA pressure, RV pressure, with this simultaneous ballooning of the pulmonary arteries, and the patient became tachycardic and hypotensive, and you can actually see that there is extravasation of blood on the left-hand side. So she finished up with a large pleural effusion, in fact, hemothorax, and that had to be drained. The surgeon came into theatre, opened up, and found a tear at the proximal end of the left pulmonary artery, which he closed. In terms of hemoptysis, to me, this is the most serious, because once your lungs get flooded with blood, these patients do not have a normal blood supply, you may have a big problem with ventilation. Yes, you can put them on ECMO and so on, but that is not always easy or possible. So very important to cross-match blood in this situation. As Dr. Boshoff mentioned, use bilateral bronchial rather than brachial intubation. Reverse the heparin. You can inflate a low-pressure balloon at the site to reduce the bleeding, and it works. And the left side then needs to be, or the affected side needs to be lavaged so that you remove as much of the blood to improve ventilation. But that may take time, and it will require high-pressure ventilation. One of the cases I showed you earlier was very successful dilatation of the right pulmonary artery in an laryngeal. We then did the same thing here on the left-hand side, starting with cutting balloons, going with a standard balloon. Once we went with a standard balloon, there was gross hemoptysis. So we did again, we reversed the heparin, put a small balloon, and you can see that the bleeding has actually stopped. We took the patient to intensive care unit with clear instructions not to take the balloon out until the following morning. It was deflated by the time he got to the intensive care unit. For some reason, the intensivist decided to take it out during the night, and he developed a bleed in the morning, which proved fatal. This is just to show you that the ET tube, you can see that this patient has a tube going into the left bronchus, and the main one which supplies the right. So if you have a bleed on the left-hand side, you can put a cuff here. If you have a bleed on this side, again, you can put a cuff here so you can ventilate this lung. If you have enough blood supply, at least it gives you an opportunity to put them on ECMO and to stop the bleeding. I think from what the anesthetist tell me, the patients need to be about 10 years or older before you can put one of these double lumen bronchial tubes. So in conclusion, pulmonary artery interventions do carry more risk than other interventions. I think in part because of the pathology. There are multiple lesions, repeated procedures, but also limited control. When you have bleeding within the lung, it is a problem. Controlled angioplasty, either with a stent or with a cutting balloon, minimizes the risk, no question about that. There is no hoop effect when you use those procedures. And I think you must have bailout options in place in advance prior to doing any ballooning of these pulmonary arteries, because when you have a complication, things happen very, very, very fast indeed. Thank you very much.